Good morning, everyone, and thank you to the Ask About Asthma team for inviting me to talk today. I'm Jen Townshend. I'm a paediatrician in the northeast of England and the National Clinical Lead for Children and Young People with Asthma at NHS England. I'm sorry I can't be with you live today, but I hope that I'll be able to join at the end of this presentation for any questions that you might have. So the theme for this year's conference has been about supporting children and young people with asthma to live their best lives by having the best possible control of their asthma. And the Ask About Asthma campaign focuses on getting the basics right and the fundamentals of good asthma care that all children and young people with asthma should expect, because we know that they are associated with better outcomes. But in order to achieve these asks, we need to go one step further back, because there are some even more fundamentals of asthma care that need to be assured in order for these asks to be achieved. And these are around making sure that children and young people have an accurate diagnosis, because this is the foundation to good asthma care. And that accurate diagnosis needs to come early on in their asthma journey, so they're not suffering with avoidable symptoms and limitations on the quality of their life. We need to ensure that all healthcare professionals that look after children with asthma have the appropriate level of training and skills in order to do this safely. We need to make sure that patients and families are supported and educated to self-manage their asthma, because we know that this is associated with better outcomes. And underpinning all of this, we need to tackle the health inequalities that exist around children and young people's asthma. And over the since the publication of the bundle since the publication of the bundle, there has been progress made in all these areas, but there remain a number of barriers to successful implementation of these. And over the last year, we've been working to remove these barriers as much as possible at a national level. So over the next 20 minutes, I'm going to talk you through some of the work that we've been doing, and I hope that this will be practically useful for you to take away and integrate into your everyday care, be that the clinical care that you offer, or whether that's at a strategic level to improve the services that are offered to children and young people in your area. So we'll start with looking at how to ensure an accurate and timely diagnosis to all children and young people with asthma. So this has been a challenging area and something we've put quite a lot of time into this year. I don't think I need to convince anybody that getting an accurate diagnosis is hugely important. It really is the foundation to getting good asthma care. There's significant over and under diagnosis of asthma. We know that some papers show that up to 45% of people that have a diagnosis of asthma, in fact, don't have asthma. And the problem with this is it trivialises asthma and feeds into this ambivalence that we're fighting so hard against. But even more concerning is that 10% of children and young people who have asthma don't have a diagnosis. And without this, they can't get access to the structured care, which is essential to good asthma outcomes. We know a lack of diagnosis is also a foundational driver of health inequalities, and families feed back to us that getting a diagnosis is crucial, and for them they feel it's a turning point in the care of their children's asthma. But the journey to getting it is often quite long and fraught with obstacles. And I think one of the main challenges around getting a good and accurate asthma diagnosis is, unlike other chronic health conditions, there's not one single gold standard test that gives us a definitive answer. So the diagnosis has to be based on a combination of history and examination, objective testing, review the results so they can be applied to the clinical picture, possibly then a trial of treatment, and then a review with a further history and examination following that trial of treatment. And the loop can sometimes go round several times before a diagnosis or a not diagnosis is reached. And so this can be quite a complex procedure, and achieving it in primary care requires new diagnostic models to be created in the form of, particularly for objective testing, in the form of hubs or hublets, or using community diagnostic centres or CDCs. And there has been a number of barriers to this, and this is evidenced by the feedback that we've been getting from the deliverables from the bundle. So this graph looks at all the deliverables from the bundle, with each ICS reporting their progress and giving themselves a colour RAG rating. So if they give themselves red, they're really making no progress at or amber progress but with quite a lot of difficulties, green steady progress, or blue complete. And you can see that the deliverables related to early and accurate diagnosis are these three here, and in terms of completion rates you can see that they're amongst the worst achieved deliverables, and this is because there really has been a number of barriers to setting up these diagnostic pathways. And we've tried to tackle each of the barriers independently, and some progress has been made. So we'll start with prioritisation and funding, because these are both intrinsically linked. And I think feedback from systems has shown us that I think the messaging to ICBs has not been as directive perhaps as it would be useful to have been. The guidance could have been interpreted that children, including children and young people in diagnostic models, was optional. That guidance has now been updated and quite clearly says that systems are expected to offer services to children and young people locally within CDCs where it is safe and appropriate to do so. And if it's not safe or appropriate to do so, that alternative plans do need to be put in place. I think that guidance is currently still in draft form, but you can get it off the Futures platform, and it should hopefully have gone through publication in the coming months, and will provide a degree of leverage to prioritise children and young people's diagnostic services at an ICB level. There's also been messaging from the CDC team that ensuring asthma pathways are created is a priority area. There are 3 priority areas this year from the CDC team, and one of these is CYP asthma pathways. And there is a funding bid open at the moment, and the plan is that there's one CDC in every ICS that develops a functioning CYP asthma pathway, and there is funding available for that. So I think bids are currently being put together, and if you want any further information about that, you can contact us and we'll forward it on to the relevant team. There was also there's also when any new bids are for new CDCs are sent into the national team, and there will be a specific question about provision of CYP services, and this will need to have been explored for the bid to be successful. And there's also new commissioning standards for spirometry, which will be available on the NHS website shortly, which simplifies and provides more clarity for what is expected in terms of standards for spirometry. So I hope the combination of these things will mean that the messaging to ICBs is clearer, that CYP diagnostic pathways are a priority area. There's also been barriers in the form of training. So in order for spirometry to be delivered, it needs to be quality assured, and this means that anyone performing spirometry or interpreting spirometry needs to have been accredited and be on the ARTP National Register, and that means they need to have passed an assessment and done appropriate training. And there has been difficulties reported to us both in terms of accessing training and accessing the accreditation process. So the national team has been working with the ARTP, and the accreditation process is being made simpler and smoother, and ARTP has previously not been responsible for providing training, but a new online spirometry training course is in development, and the content for that course will be provided by the ARTP. So I hope that the barriers to training will be removed, or at least be diminished. Another barrier has been just a lack of knowledge of what are the specific requirements if CYP are to be involved in any diagnostic pathways. So to help with this, a new document has been produced which looks at the age-specific considerations when developing diagnostic models. And this is a very practical document that outlines the specific steps that need to have been gone through in order for CYP to be part of a diagnostic pathway. It looks at safeguarding requirements, training requirements, the environment, equipment and appointment times, and provides documents to support implementation of these different requirements. requirements. And again, that's available on the Futures platform. And finally, I wanted just to mention that there has been some concern around QOF and the indicator around asthma diagnostics. The indicator here wanted a large percentage of children who were on the asthma register who had a diagnosis of asthma to have had objective testing. But in the current environment where these services aren't set up, it's either meant that secondary care has been flooded with referrals for objective testing, which they are not set up to provide, or it's actually created a perverse incentive to diagnosing children. So children haven't been given a diagnosis so as not to affect the QOF payment. And as we mentioned earlier, without a diagnosis, they don't get access to all the structured care that they need in order to improve their asthma care. So we just wanted to point out that within this indicator, there are exceptions or PCAs available. So where objective testing can't be performed, either because the child or young person simply can't do it, or because it's currently not available, this box can be ticked and they are removed from the denominator, and it doesn't affect the QOF payment. This is likely to be a temporary measure and shouldn't deter from setting up diagnostic pathways. So then moving on to the training of healthcare professionals, we know from the NRAD report and from the HSIB report how important it is that healthcare professionals are adequately trained, and that every contact with an adequately trained healthcare professional can make an important difference to a child's asthma care. A number of online courses have been developed in line with the National Capabilities Framework, and these are tiered according to what level of care that professional is delivering to that child with asthma. These courses were went live about 2 years ago, and over that 2-year period, nearly 50,000 people have completed at least one of the training courses, which on the face of it is a huge number, and it will make a noticeable difference. But when you look at the details of the numbers, the vast majority of these numbers are in the tier 1 training levels, with significantly less at the tier 2 and 3 levels. So looking at the sort of barriers to why the numbers aren't quite so high in these levels as we would hope for, seems to be 2 main areas. The first is around prioritisation. So although these online courses are free, people's time is not, and particularly the tier 3 courses is 6 hours long. So finding time for people to do that within the demands of a busy work day has been difficult. So we have worked with the NHS Standard Contracts team, and a service development and implementation plan has been included in this year's NHS Standard Contract. And this asks that systems try and ensure that the asthma training is prioritised for all the healthcare professionals that should be doing it. It's worth saying that the NHS Standard Contract is aimed at secondary care and any services that are outsourced from secondary care, and doesn't affect primary care or community care. And this is an area that we are hoping to work on in the future, because the majority of children are in primary care. It's a very there's a lot of demand placed on professionals that work in this area, and we need to find a solution to ensure that they've got the time to be adequately trained. The second barrier to increasing uptake of training in the higher tiers has been around the fact that it's an e-learning module, particularly for the tier 3 module, which is 6 hours long. A number of people have commented they would prefer to have face-to-face courses, and a couple of pilot courses have been run in Cambridge and in London and had good feedback and good turnout. So I think there is a role for having both e-learning and face-to-face courses, but we do need to ensure that the courses are standardised, that we know that every course is delivering the same content and is accredited. And so to try and implement this, there is a team that is coming together to develop a national package of training resources for a face-to-face course. And this is being led by Viv Marsh, who has a vast experience in asthma education. And we hope that 4 pilot courses to try out the new materials will be run by the end of March, and that the new materials will be available for further rollout after that. So we'll let you know more about that as it happens. And then looking more towards patient self-management. So we know that self-management is hugely beneficial in chronic disease. It can reduce ED visits and hospitalizations. And we know that any chronic disease that is self-managed has better outcomes. There's a number of resources that have been developed, and they're available on Asthma Lung UK and on Beat Asthma, specifically for children and young people with asthma. But most recently this year, the most popular resources on Beat Asthma have been converted into Easy Read, and this will be available in a new Easy Read section. And there's a number of leaflets and information sheets, and there'll be 2 videos as well. And these should be available within the next month or so on the Beat Asthma website. There's also information for parents on how to manage preschool wheeze. These resources were put together following a national working group and are available both on the Futures platform and on the Beat Asthma website. And they include how to reduce the salbutamol inhaler after a preschool wheeze attack, and an information leaflet and wheeze management plan. There's also resources for professionals, again put together by this national group, to help in the management from a professional's perspective. And then another area in terms of patient self-management that we've been working on this year has been around the lack of dose counters on salbutamol PMDI inhalers. This has been a concern for some time. We know that without a dose counter, there's no reliable way for patients to know when their device is empty. They can sometimes incorrectly believe that puffing it or shaking it is a way of telling if it's empty, but often that can just have a propellant in it and no actual active ingredient, so it isn't a reliable way. And studies have shown that 40% of patients use an inhaler which they believe has got doses remaining in it but is in fact empty. And the consequences of this is that studies have shown that it can increase unscheduled hospital visits by 45%, and there have been concerns that it places individuals at risk of life-threatening asthma attacks because they don't have salbutamol available when they need it. I know that later on this morning you're having a talk by the National Child Mortality Database and the findings of their deep dive into asthma and anaphylaxis care following child deaths. So I don't want to dwell on this too much, but they have found that there have been a number of deaths where the absence of a dose counter has been a contributing factor. So these concerns are well-placed concerns. Patients also report anxiety over not knowing how many doses are left, and that anxiety improves if a dose counter is fitted. And there's also the environmental impacts of not having a dose counter. People get rid of inhalers which have got drug left in them, and these then go to landfill where they can, or potentially go to landfill where they continue to release their HFAs into the environment. So previously, we've done work to try and improve education on the concerns around a lack of dose counter by including paragraphs in the BNF and BNFC and each of the tiered national training e-modules containing information around the dangers of lack of dose counters. And leaflets have also been developed for patients, which are available on the Beat Asthma website, and most recently will be available as Easy Read and animations. There has been a patient safety alert that went out this year, and the CDOP reviews have been asked to submit yellow cards whenever the lack of a dose counter on a salbutamol inhaler is thought to have contributed to a child death. We've worked across the system, across adults, pharmacy, to try and work together to understand what we could do to try and improve the situation. But most recently, we've looked at the international response, where the FDA, the EMA and Australia have all supported the inclusion of dose counters on PMDIs. And we've recently been working with the MHRA, who have prioritised this now as a significant safety issue, and are working proactively with partners in the pharmaceutical industry to try and ensure that all PMDIs do have an integrated dose counter. So this is currently work in progress, and I hope that we can make significant steps forward on this over the coming year. And then finally, we've made further contributions to how we can tackle health inequalities with the release of the dispensing dashboard. So this dashboard looks at all dispensed SABA and ICS inhalers down to patient level across England, and looks at each individual patient and puts them in a risk category according to how many SABAs they've been dispensed or how many ICSs they've been dispensed, and then we group all these risk categories together so you can get an overall picture of the number of patients who are at various levels of risk. And we can also look at that right down to PCN level. So within an ICS, an asthma lead is able to look at the numbers of patients who are at different levels of risk, and identify the PCNs with the highest numbers of patients at risk, where they can then have more targeted care. The dispensing dashboard doesn't go down to individual patient level, but the CDRC, the Clinical Digital Research Collaborative, have produced searches which are freely available on their website and are compatible with EMIS and System 1. So once those PCNs with high numbers of at-risk patients have been identified, these searches can then be downloaded at the individual practice levels, and children between the ages of 5 to 18 who've had 6 or more SABAs or 2 or more courses of prednisolone will then be identified using these searches. So then care can be delivered in a targeted way to try and help improve their asthma outcomes. So this was a whistle-stop tour through the work that we've done over the last year to try and tackle some of the barriers to implementing these fundamentals of good asthma care. I just want to say that what we've done is very much based on the feedback we've had from you and the comments that we have on the various different platforms that we communicate with you on. So please do keep feeding back to us, let us know how things are going, and I hope we can continue to work together to improve asthma outcomes and quality of life for all children and young people. Thank you.